we are live in 5, 4, 3, 2, 1. We are live now.
So, good evening, everyone. On behalf of Rajasthan Orthopaedic Surgeons Association, I, Dr. Rahul Katta, Honorary Secretary of Rosa, welcome you all for this another series of master classes in hand surgery. Today, the topic is a very common topic, the carpal tunnel syndrome. And we have the galaxy of national faculties as well as the Rosa faculties and the local faculties for today's discussions and the webinar. To start the formally this webinar, I would like to invite the President of Rajasthan Orthopaedic Surgeons Association, Dr. Vinay Goyal, formally inaugurate the proceedings of this webinar. Over to you, Dr. Vinay Goyal, sir.
Good evening, everybody. And Amit Vyas is doing it very consistently. And this topic is really very important topic. We see these patients day to day, and there is always some dilemmas in diagnosis and mode of treatment also. So I hope we will learn a lot from masters, and please start the proceedings.
Thank you, President sir. So to start with the proceedings, today's moderator for the webinar is Dr. Amit Vyas, who himself is a renowned hand surgeon from Jaipur city. And we have a galaxy of the faculties. I would invite Dr. Amit Vyas to introduce the faculty first and then start with the proceedings of today's webinar. Over to you, Dr. Amit.
Thank you, sir. So today, as President sir has told that we are going to discuss about the carpal tunnel syndrome. The main focus will be about the diagnostic part and whatever differentials are there. So we will try to how to differentiate it from some coexisting and some similar conditions. So for that we have invited first Dr. Anil Bhat sir. Dr. Anil Bhat sir, he is head of the hand surgery unit and head of the department of Kasturba Medical College, Manipal. And although he doesn't need any introduction, but he's a renowned hand surgeon, and he's involved in a lot of academic activities. He has more than 80 publications and more than 400 guest lectures. And recently he's the appointed as a chief of the ISSH research wing. And he's also coordinating the American Society of Surgery of Hands surgical video. And he's editor of Hasta 3D printing, and he's doing a lot of work in the congenital anomalies. And second speaker is Dr. Parag Lad. He's working at Jupiter Hospital, Mumbai, and he's a renowned hand surgeon. And he has more than 10 publications and more than 50 guest lectures. And third one is Dr. Amit Varade. He is working at Sopan Hospital, Nasik. And he has enormous work in the wrist arthroscopy. And after that, our special guest is Dr. Neetu Ramrakhyani. Dr. Neetu Ramrakhyani, madam, she is basically a neurologist, and she's the director and head of the department of neurology department at Fortis Sports Hospital, Jaipur. Madam has enormous work in peripheral nerve surgery, and I would say I'm taking help every day with the madam for diagnosis of the complicated case of peripheral nerve injuries. And then we have our galaxy of a star, Dr. Jaswant Singh ji. He is working at Kota, and he is renowned hand surgeon and orthopedic surgeon. And then Dr. Narendra Saini, he is associate professor and of the SMS Hospital, Jaipur. And Dr. Girish Gupta, he is renowned hand surgeon at Narayana Hospital. So with this introduction, first of all, I would invite Dr. Anil Bhat sir to deliver his talk on the carpal tunnel. So the order will be like that. Sir will tell the clinical diagnosis. Then Dr. Neetu Ramrakhyani madam will tell the role of EMG and CV. Then Dr. Anil Bhat sir will tell further about the diagnosis and differential diagnosis and other diagnostic modalities. And also he will show some surgical techniques. Then Dr. Parag Lad and Dr. Amit Varade will and I will present some case and will discuss.
Sorry, Amit, I'm interrupting you. You forgot ma'am to introduce ma'am. So welcome, Dr. Purnima Patni. Ma'am, she's a very senior and renowned orthopedic and hand surgeon from our city and president of Jaipur Hand Surgeon Society. So she's also faculty and the part of this webinar. So now you can proceed.
Sorry.
जनरल सेक्रेटरी याद रखता है भाई.
So Dr. Anil Bhat sir, we welcome you and please deliver your presentation.
Thank you so much, sir. Thank you, the Rajasthan Orthopaedic Association and the Jaipur Hand Society. It's always nice to come back for these sessions and see Madam Dr. Saini, Amit, everyone again. As Amit said, I'll start basically with the diagnosis itself. Is my audio fine?
Yeah.
Yes, sir.
Yes.
बहुत better रहेगा, सबसे बढ़िया रहेगा.
So I always wonder when I look at the carpal tunnel, why God created this tunnel where the nerve is hidden among all these tendons here and supported by the carpus here and a fibrous tissue covering here. And then you have the ulnar nerve, which is actually the nerve of the hand, which supplies most of the muscles of the hand. It is kept superficial here. But then I think God created carpal tunnel only to trouble hand surgeons, probably, or orthopedic surgeons. So when I see this anatomy, I always get this feeling about that. But apart from this, it's basically this content and, the canal and the content, that mismatch is the problem most of the times for carpal tunnel. And that's what the etiology is always in terms of the mismatch of the content versus the canal morphology itself. And that's where we struggle. And that's where the etiologies come in. There could be physiological states like pregnancy. Please remember that. And it might not require any major management, except that you just wait for the pregnancy to be over. Some patients do come back later on. Pathological states are one which we are looking at. And even though people talk about the content versus canal morphology, and canal morphology can be a major factor because it's common in females, and also that the tunnel size can vary in some pathologies like malunited distal radius fractures and so many things. The pathological states are the ones which basically give rise to the carpal tunnel syndrome. As a surgeon, personally, clinical diagnosis is very important for me. I need to convince myself that it is carpal tunnel syndrome. It's not something else. And if it's not very typical, that is where the danger comes in. And we should not assume everybody coming with pain and paresthesia in the hand is having carpal tunnel syndrome. So investigations come later on as a supplementary only, basically to rule out other conditions when we are in doubt. That is what is important. And sometimes maybe we can also image like an ultrasound or an MRI rarely can be used to image the tunnel itself, but otherwise investigations are always secondary for me. So that's where the diagnostic criteria comes in, where very, very important is that when you talk to the patient. thorough history. I always ask the patient, one of the things I always ask is, since how many years you have this, symptoms? Because most patients, they don't tell that history properly. And you assume, because they come to you only when it becomes worse. And that will be maybe 2 months, 3 months. So you assume that it's just there for 2 months, 3 months. But if you probe further, it's always that they'll have it for 2 years, 1 year, 2 years, on and off. But they're not really worried about it. So a thorough case history is very important, because the prognosis of the case is dependent on the duration. The longer the compression, the longer the nerve takes to recover, even if you do surgeries. So this is very, very important, and also important a lot of times in medical legal aspect also. Nocturnal paresthesias early on is one of the major symptoms you should be asking for. And a lot of people sometimes deny, telling that no, it's there more in the daytime, but that's happened only later on. When it becomes almost continuous, then they feel it even in the daytime. But if you really probe again, it's actually the nocturnal paresthesias which actually start early on. Provocative factors in terms of hand position and movements, especially for certain occupations, you need to ask. What instruments used, what vibrating tools, so working activity, it needs to be probed into. And where is that numbness? Where is the paresthesia? Where is the pain? And what is the duration, radiation of this? Very, very important, especially if you're dealing with some other condition apart from carpal tunnel. So you should assume that it is something else. If at all patient is now showing not very classical symptoms and signs, be very careful on this. Predisposing factors, always rule out a set of conditions, including diabetes, hypothyroidism, rheumatoid. 3 conditions immediately you need to ask all these patients. And what alleviate their pain or paresthesias. Again, very, very important for us to know whether how they respond later on for your splinting and other management. This is the American Hand Society 2003 criteria, where they have lined up all the tests here, how it is performed, what is the condition to be tested, what is the positive result, and how do you interpret this. And the Durkin's test is one of the most specific tests as per the almost 90% specific. One of the highest specificity comes from the carpal tunnel compression test or the Durkin's test. This is the Phalanx test. This is a classical way of doing the Phalanx test, but people also do it like this. And this is how the Durkin's test has to be done. This is shown in the original article. I'll show you later. So compression along this for about 30 seconds. Paresthesia within 30 seconds is what is positive test. So you need to span the carpal tunnel. Okay, a lot of people just keep one thumb there or keep both the thumbs together at the same place, but this is how it needs to be done, and the compression has to be applied. Now, if you look at other tests, right, if there is distal latency, conduction velocity, and there is latency there, or even motor latency, sensory and motor, they're probable CTS, because the NCV picks up the moderate and the severe ones. The mild ones are not picked up initially because the myelin is still intact. So that's our understanding of this. So sometimes the NCVs can be normal, and so you might have very early carpal tunnel syndrome, which might be missed. And EMG, when there is fibrillation potentials, sharp waves, you know that denervation has started. So this is an advanced motor neuropathy which the patient has. But the diagnostic criteria later changed. The CPGs, the clinical practice guidelines, which came in 2016. This was a group of people, experts who had this meetings, what's called as the Delphi kind of methodology. So symptomatic compression neuropathy of the median nerve at the level of the wrist, characterized physiologically by increased pressure within the carpal tunnel and decreased function of the nerve at that level. That was the basic definition of carpal tunnel. And they did develop and validate the diagnostic criteria. And this is the final list they arrived at of the clinical diagnosis. This is a clinical, remember, clinical diagnostic criteria, not investigations. So all these numbness, nocturnal numbness, weakness or atrophy of thenar musculature, tinals and phalanx, loss of 2 PDs, what is the exacerbating factors, coexisting medical conditions. So these are the ones they thought were very important, and they actually created a lot of case scenarios based on these, almost 256 unique case histories, and checked whether it matches. And this is the final criteria they had. Now, if you look at the Phalanx test, this is the original article 1966 of Phalanx. And this is the figure which is given there. This is how we need to do the variance test. So a lot of times people do it this way or this way, but this is how we need to rest the elbow on the table like this, drop the hand like this, and ask the patient to hold it. Phalanx tells 30 to 60 seconds. Of course, now we do it standard as a 60 seconds, but this is not important. What is important, how soon the paresthesia comes into the patient, right? So if patients tell within 10 seconds, they are within 20 seconds, you know that the compression is severe. That is very, very, when we record Phalanx test positive, that positive record should be how many seconds. That's very, very important for us to know the severity of the condition. Phalanx plus Tinel, strong evidence, both of them not to use it. Now, Tinels here is not the Tinels what we talk about, the nerve recovery. Okay, this is a Tinel test. Some people call it Tinel test. Is basically compression on this particular area, a tapping of that area, and because there is loss of myelin sheath, sometimes patient has these numbness and paresthesia. So this is what is different from what we do for a regenerating nerve. So Phalanx or Tinels should not be used alone. That's what they said. It should be used in a combination, because when you use both together, specificity increases to 93%. By themselves, they're just 70 to 80%, right? But if you add both, it becomes 93%. So this is what was recommended by this group, the Clinical Practice Guidelines group. Durkan's. This is the original Durkan's paper, John Durkan's paper here. And you see this is how he shows how to do the Durkan's test again, right? And within 30 seconds, it should be positive, a very, very specific test there. Other tests, along with Durkan's or 2-point discrimination, monofilament, and scratch collapse test, which was later described. Moderate evidence, again, not to use alone. You have to use them in combinations. This is what the committee tells. And this, again, the provocative test, different sensitivity, especially the black one is sensitivity. This is specificity. This is the positive predictive value, and this is the negative predictive value. So each of them, if you see, has different kind of values there. But if you add two of these, right? So they said that commonly performed provocative tests differ in sensitivity and specificity. But as the examination maneuvers become more provocative, the tests become more sensitive, which means if we add two tests, like if you add the Phalanx and the Durkan's together, and they named it as, I can't pronounce this, but it's PH Durkan test. That's what I would tell, right? So if you add these two, if you see here in this graph, the sensitivity and the positive predictive value goes up very high. Okay, so that is how we need to probably combine tests. That is the message of all these guidelines, that combination of the test is good for carpal tunnel. Now, thenar atrophy is a very strong evidence for ruling in carpal tunnel, okay, but not ruling out carpal tunnel. A very specific, this is specific basically means you can rule in that definitely this patient has carpal tunnel, but it doesn't, does have a poor association for ruling out carpal. They can have some other conditions also. So we need to be careful about that. The other criteria used were questionnaires. The CTS-6, which came from the same group, the hand diagram, and the classic Boston carpal tunnel questionnaires. These are the ones. So this is where they give the scorings for symptoms, numbness, physical examination, the 2PD discrimination, and Tinel sign, everything. Score of 12 represents almost 80% probability, right? That came from the same group as who developed the CPG guidelines. And this is the hand diagram where patients themselves draw this. Again, sensitivity of 80%, but it's quite cumbersome for patients to draw and show you all these things, or you draw this. And the classical Boston carpal questionnaire are two parts. One is the symptom severity scale, and then the other one was the functional status scale. So these, again, elaborate questionnaires, which we have to use sometimes is difficult in the clinical practice. So we just stick to the initial ones, which I told you. I think I'll stop at this, Amit, and come back later for the rest of it.
Yes, sir. So now I would invite Dr. Neetu Ramrakhyani. Up to this time, do we have any questions from the other faculty? Madam, please share your screen. Madam, could you please share your screen? Sir, what is McMurphy test?
Can you come again, please, Amit?
McMurphy test. What I feel that you told, no, pH, Durkin.
Yeah.
The combination of.
Yeah. So it's basically both the things. So you're doing all the phalanx itself, and also you're giving compression here. So basically you're increasing the provocation of the compression itself. So adding up both will obviously increase the sensitivity of the test and also the positive predictive value of the test itself. That's what they did, and they found that actually in the clinical studies.
May I ask a question to Dr. Bhat, sir?
Yeah, please.
Yes, Parag. Yes.
Yeah. Sir, can you please elaborate about how to diagnose a carpal tunnel with flexor tenosynovitis and how to analyze pre-op that apart from decompression, some patients do require a tenosynovectomy in your experience?
Right. So those are the patients who have pain as a major component, right? So that is the first thing which strikes you, because most of the patients, they always come with numbness and paresthesia. The pain is there, but might not be major component. So if you have a rheumatoid patient or any kind of patient with tenosynovitis, the pain becomes more bigger component than the paresthesia itself. So there is a combination of both, and you need to check which is more. That is the first part of it. The second, you would want to add your clinical test in terms of diagnosing tenosynovitis, which basically means anything, you know how the tenosynovitis is diagnosed, right? So extension opposite movement, when you do that, it is painful. Same side movement with resistance is painful. Two classic tests for any tenosynovitis, right? So you extend dorsiflex and extend the fingers, it should be painful if it's a flexor tenosynovitis, right? And on resistance with flexion, it becomes very painful for the patient. So this is how you add, apart from the carpal tunnel test, clinical test, which I showed you, add the tenderness part of it also. So this is the way to diagnose it. Yeah.
Thank you so much.
If I may ask one question, please.
Yes, sir. Yes.
Yes.
Yeah, I mean, part of my question was asked earlier, so you answered that very well. In our scenario, most of our patients, especially those who are coming from relatively illiterate background, most of the scoring systems may not work. So perhaps, at least in my practice, I would say TINELS and Phalanx are the two tests I would perform with high index of suspicion and maybe 2-point discrimination to diagnose CTS, and then, if available, do an EMG. So if we want to give a message to those who are doing non-specialized hand surgery practice in their clinic, what are the two most dependable, what is the advice you will give that, okay, if these are the tests which were done clinically, you can be almost 80-90% sure you are dealing with carpal tunnel.
Right. Again, it's not about anybody having specialized hand surgery thing, or it's basically clinical diagnosis at the end of it for all of us clinicians. So for me also, it's basically the phalanx and the Durkin's, which gives me most of the time my diagnosis. These are the two tests which I would do most of the times. And then I would check the sensation and document the sensation always, so that we don't miss early kind of sensory changes in these patients. So I really do TINELS and other things, but otherwise definitely the phalanx and the Durkin's is what I rely on most of the times. Plus add the sensation part for our documentation, so that it has a medical legal consequence if at all you're operating also. So you carefully add the sensory part, because patient might have sensory disturbance earlier itself. So that needs to be documented.
And what is the percentage of patient you would do EMG NC before proceeding for surgical management?
Okay. Again, nerve conduction is basically for documentation for me personally, in the sense that it is always for ruling out other things. Definitely, if some things are not matching, I would definitely ask for a nerve conduction for me to say that this is definitely carpal tunnel. So that is one thing. But otherwise, in an institution practice for us, they come with a nerve conduction study most of the times. Actually, I do a lot of ultrasound actually, because I basically operate endoscopic carpal tunnel release. So in that sense, I rely more on ultrasound to see the morphology of the tunnel and anatomy of the tunnel. And that gives me a lot of information about the carpal tunnel itself. But yes, nerve conduction study has its place for documentation, for ruling out major other conditions. And the basic diagnosis, it is not a gold standard, it's a reference standard. That is what it's called as. So madam is there, she would definitely highlight a lot of things, but there's no gold standard investigation for a carpal tunnel syndrome.
Sir, may I ask one more question?
Please.
I have found that patient with carpal tunnel typical symptoms, most of the time they have some cervicoscapular pain, and these settles with the treatment of the carpal tunnel. So how you explain?
I'll come to the differentials. I'll be telling you everything about double crush and everything later on. I think that answer your questions at that time. Yes.
And second thing, yeah, just one thing, sir.
Yes, sir. May I just add on the Amit's experience? Most of these cases usually comes in the winter, and as soon as the winter goes away, the pain also subsides. Number one. And during the winter time, when we test, they find positive. But as in the summers, all the tests are negatives. Number one. Number two, even the NCVs and studies are also varies with the time, due course of time. How do you experience? Number one, what is your experience, Dr. Bhat? Number two, as far as the double crush syndrome, most of these patients, they never come with the typical symptoms of pain in the index or thumb or some weakness. But they have the vague pain in the upper limb. Sometimes you find cervicobrachialgia when you get the MRI study done. Most of the time, the MRI studies is also not contributory. So on the clinical basis or on the basis of just clinical history, we operate and find that these, in real terms, the TCL, deep TCL was tight, and and the nerve was, as soon as you release that, you find there is some vessels appears on the nerve, and the nerve starts just dilating just post-operative period. So I want to just ask from you, what is your experience about this? Dr. Bhat, please.
Yeah, to answer your first part in terms of change in the weather, probably one of the things we can associate them is with some amount of rheumatoid kind of a background. So these are the patients with an inflammatory kind of arthritis who have this typical change in seasons. That is what we find very commonly, even for joint pains and other things. So I think that is where we need to work up these patients when they present this kind of things. The second part, double crush, even now, if I look at the latest literature, there is absolutely no specific mechanism described. There are a lot of theories, a lot of plausible theories. I'll put it up later about that. But there is no specific one single mechanism described for a double crush syndrome. And so we are still in dark about that. And the fact that a lot of people tell that you release carpal tunnel, other things go away is not true, because actual clinical studies done with the double crush where they've released carpal tunnel, actually those patients have done worse. So if there's a proximal compression anywhere along, and if your diagnosis is accurate about double crush, please make sure that you treat the proximal compression first adequately and then come down to the distal part. So this is the basic guideline given by most of the guidelines, and that is what we follow. So as much as possible, be conservative in these patients. Do not operate in the early stages. Wait for things to settle down, especially with conservative management, especially the proximal kind of whatever symptoms they have. It could be cervical disc bulge. It could be thoracic outlet syndrome. It could be any of these things. But diagnosis should be accurate. You should exhaust all your investigative procedures for diagnosing where the double crush component is. And it need not be just double crush in the sense one place above, one place below. It could be anywhere along the nerve. And patients with diabetes and other kind of conditions, they have multifocal kind of compression. That's what people have found. And it's not like a single mechanical compression. So the concepts are changing now with this double crush syndrome.
Is there any constitutional finding in these patients of a double crush? Because many of these cases, when you operate there you find some proximally also there is some tightness in the pronator teres or some fibrous band. Most of these patients have this trigger finger decurvence. Most of these patients have multiple small collagen diseases of fibrous bands, which leads to compression neuropathies.
There is this kind of thought process about even autoimmune related, so many different things. That's why I said double crush is not just mechanical compression at two different levels. The thought process now is that it's a multifocal pathology, which could be related to inflammatory, autoimmune, diabetes, any of these things. So very important for us to know what is the accurate diagnosis. Yeah.
So I think we should come to electrodiagnostic part. Madam, please share your screen. And
thank you, Parag. Yeah, thank you. Am I audible?
Yes, ma'am. Yes.
Yeah, okay. So what I'll be talking of is electrodiagnosis in carpal tunnel. If things get too complicated, you can stop me in between. So I've started with the biophysics of electrodiagnosis. So the normal muscle and nerve at rest, they have a stable resting transmembrane potential. That means there are positively charged ions outside and negatively charged ions inside. Now, during depolarization, there is generation of current flow across the membrane, which is what we pick up in the electrophysiology lab. So there'll be terms I'll be using during my talk. So I thought I'll just go over the terminology once. So we'll be talking of action potential, time, which is the latency, the compound muscle action potential, and the sensory nerve action potential. So these are the terminologies which we will see frequently during my talk. So basically, what is nerve conduction study? So I would say nerve conduction study is a technique for assessment of nerve, root, neuromuscular junction, and for muscles. Now, there was some discussion about temperature a little while ago. So what are the variables which affect the nerve conduction? So the age of the patient, the temperature. So ideally, all electrophysiology labs should standardize the temperature when the nerve conduction studies are being done. And the ideal recommended temperature is between 32 to 36 degrees centigrade. If it's too cold, the hand should be warmed before the study is started. There are certain technical pitfalls whenever we are doing the study. People who are very obese, patients who have a lot of edema, those patients can be the confounding factors with patients when we are doing the nerve conduction study. Also, the height, the weight, and the gender affect these studies. So there are three major components when we do these studies, which is relevant to this talk. One is the sensory nerve conduction, the motor nerve conduction, F-wave study, which is the proximal root study, and the needle EMG. So what are the equipment which we use for the study? So we have three kinds of electrodes which we use. One is what is called as the active electrode, the reference electrode, and the ground electrode. And these electrodes also come in different shapes and sizes. So they can be the ring electrodes and they can be the bar electrodes. So when we say action potential, which is what we actually measure in the lab, that's the differential between the active and the reference electrode. And the third electrode which is applied there is something called as the ground electrode, which is the zero reference voltage point. Now, if you can see my pointer, how is a typical graph made? So a stimulus is given to the nerve. So here is your stimulus. This is the conduction. This is where the potential starts and ends. So these are the measurements which are used when we are measuring or describing these nerves. So the first is distal latency, point from stimulus to the onset of this graph. Second is distal duration. Again, at the second point when it is given, this is the proximal latency and the proximal duration. So basically what we do is we sum up the electrical activity of individual nerve fibers, which we activate when we give the electrical stimulus. So when we do these studies, when we say SNAP or sensory nerve action potential, that is a summation of the nerve fibers of that particular nerve which are activated. And when we use the term CMAP, it is the number of muscle fibers which are activated on giving the stimulus. There's a little technical difference between the two of them. How are these studies usually conducted? So I have also prepared small videos. I'm not sure whether they'll run or not, but I will try. So median nerve, for sensory conductions, we normally put in the ring electrode, which are placed at the index finger and the thumb. Ulnar nerve at the little finger, sural nerve behind the malleolus, and saphenous anterior to the medial malleolus. So, okay. So here you can see a study being done where these are the two electrodes. So this is our ground electrode. This is the reference electrode. This is the active electrode, and this is the reference electrode. So what we do basically is what is called as the belly tendon method. So at the belly of the muscle, the active electrode is placed, and at the tendon of the muscle, the reference electrode is placed. This is the stimulator which we are seeing. So the stimulator is placed on the nerve. The stimulator contains both anode and cathode. So when the electrical stimulus is being given by the technician on the machine, the EMG machine, you would see a small graph. So this is the first point or the distal point of stimulation of the median nerve. This is the second point of stimulation of the median nerve, the third, and then the fourth is at the Erb's point. So this is how, and see, if you can see carefully, the moment it is stimulated, you can see the muscle contracting. So there is a little bit of twitch of the thumb, which you can appreciate in this particular video. Then these points are marked, the points where the stimulus is given, and the distance is measured, because ultimately velocity is time and distance. It's a graph of time and distance, and that is how the height matters. So you have to, although there are average measurements, but ideally speaking, all patients, they should be individually measured between the stimulating points to give us accurate results. Next slide. Yeah. Okay. This is another video. Okay, so now these are what are called as the ring electrodes. So this study again is being done for the median nerve. So you can see these ring electrodes being placed. So after placing these ring electrodes in the median nerve territory, this stimulus is being given here. And since sensory potentials are very, very small potentials, they need to be amplified. And after amplification, we can separate the true potentials from the noise. So there's a lot of averaging which is done whenever we are doing these studies, because to amplify the very small potentials. You can see there, there's a graph which came in there on the video. Now the same study is being done for the ulnar nerve. So you can see the ring electrodes being placed for the ulnar nerve. And we are using this particular stimulator on the ulnar nerve. And you can see, yeah. So the small potentials are coming in and then they get averaged out and then you get a sharp peak here. Next. This is the third pattern. Now, till now, what we saw was what we call as orthodromic conduction. That means conductions in the direction of the physiology, how they normally happen. Now, this is another technique which is called as where we do the reverse, the retrograde stimulation. So here, these are bar electrodes. So this is kept in the territory of the ulnar nerve. A fixed distance of 8 centimeters is measured from these territories to the palm. And both of them are stimulated at an equal distance. Okay, so you can see here. So these points have been marked out beforehand. So 8 centimeter from the wrist crease is measured, and the stimulus area is at the wrist, and then we measure from the palm. Okay, so what are the parameters we check out when we are doing these measurements? So what we measure is the latency. Latency is the time taken from the stimulus, from the point of stimulation to the generation of the potential. The amplitude is the height of the potential. The conduction velocity, which is a calculated measurement depending upon the length over which the stimulation happens. And as I've discussed previously, we can do it orthodromic and antidromic both. So going over briefly the standard protocol for carpal tunnel syndrome. So the standard protocol for carpal tunnel syndrome would include a median study, which would be both orthodromic and antidromic, both at palm and wrist. Ulnar, orthodromic and antidromic. And then, as we saw the conductions being done in the videos a little while ago, a median from the abductor pollicis brevis, ulnar from the abductor digiti minimi. EMG usually is not done in the carpal tunnel, but only if there are certain difficult situations where we want to assess a very severe kind of CTS, or we are suspecting some other pathology. That's the case where most of the time we do EMG. So I think, again, we've gone through this. So this is the stimulus, this is the electrode, and this is how the conductions are being generated. So I'll just briefly go over 2 cases to illustrate what I want to show you. So this is a 35-year-old female diabetic hypothyroid who was presented with numbness in right hand, which increases on holding the telephone with some nocturnal worsening of pain. Patient has a positive Tinel sign and a negative Phalanx sign. Now, this is the graph. So I like to bring to your notice certain features in this graph. So these are the conductions, the median conduction on the left side. So as we can see, are you able to see the screen and see the readings?
Yes, ma'am. Yeah.
So we can see that this is 5 points. This is 6.6. That is the distal latency. And this is the conduction velocity. This is the amplitude. So these are the 3 important things we see when we see this report. This is the right median. Again, prolonged distal latency. Amplitudes are more or less preserved. A little bit decrease in the conduction velocity. So the normal cutoff is around 50. So here you see 45, here you see 39. On the other hand, the ulnar studies, 2.8 distal latency, well-preserved amplitudes, and a conduction velocity of 63. Again, on the right ulnar, 2.7, good amplitude, good conduction velocity. Similarly, for the sensory conductions, you can see this is definitely prolonged. This is 5 milliseconds. The amplitudes are on the lower side, and the conduction velocity is barely 30. Again, normal for this particular site would be 50. Prolonged amplitude here is better preserved and a low conduction velocity of 39. So what we see here is basically well-preserved ulnar conductions, bilateral impaired median conductions, which involve both the sensory as well as the motor median nerve, And this is a specific study which we do, which is called as the palm to wrist, the one which I showed you in the third video. So palm to wrist is showing that whereas the ulnar nerve is conducting at a rate of 55, the median nerve is conducting at the rate of 31 when we do retrograde stimulation. So these two independent parameters help us to confirm that what we are encountering is a carpal tunnel syndrome. So this mostly I've explained. So distal latencies are prolonged, snaps are affected, CMAPs are affected, conduction velocities are reduced, and confirmation is by the palm to wrist conductions, which show further decrement in the conduction velocity. F waves show normal latency. F waves are basically done to see the proximal segments. The proximal segment cannot be measured by these conduction studies which we do in the hand. So this is the stimulus is given from here, goes to the neck, comes back. So that is F wave. So F wave is normal. So proximally, maybe there is not much. So the impression is bilateral carpal tunnel syndrome. So that is how you arrive at this diagnosis electrophysiology. Now, what is important? So the SNAP, that is this sensory potential, the NCV is either there is a slowing in absolute terms or there is a slowing by comparison. So it's a difference of 10 meters per second as slower as compared to ulnar. Again, relative latency prolongation or relative difference between the two of them. And when we do orthodromic, the amplitude should be, if it is less than 8 and less than 20 in case of antidromic. So, and also compare the two sides. Although for CTS, I don't know how useful it is because CTS usually is bilateral. But still, if you can get a difference, that is useful. Again, slowed velocity across the wrist. So less than 38, prolongation of distal latency, and absolute reduction in amplitude. So these are the parameters which help us understand what is happening at that particular site. This we have gone through. Okay. Now, what is the most sensitive parameter when I'm looking for a CTS? So the most sensitive is an orthodromic snap from the ring finger. So when we start our conduction, and if that is abnormal, we think that probably we're on the right track. The other parameters add up. Why I'm emphasizing on this particular point, we will discuss later, because this is an important point that when we are talking of carpal tunnel, we should be getting some abnormality in the snap from the median nerve on the orthodromic conduction. So what are the diagnostic criteria? The distal median motor latency more than 4.5. The difference between distal motor latency of median and ulnar more than 1.1 milliseconds. Difference between distal sensory latency of median and ulnar more than 0.2 milliseconds. And palm to wrist conduction difference between sensory and median ulnar latency more than 0.4 milliseconds. So in combination, they are quite reliable. How do we grade the severity? In mild, we might find a prolonged latency of snap. CMAPs are often normal. And EMG, usually we don't do, but if you do it, it's normal. Moderate, snap would have prolonged distal latency. CMAP would have some prolonged latency, but usually axons, the amplitudes are preserved or borderline low, and EMG would be normal. Severe snaps are often absent, prolonged latency is there, and then they would find denervation on the EMG. So this is the first case which I discussed, which is classical of a carpal tunnel syndrome. Now we'll go on to the second case. Now this patient, he had pain on right side of the arm and forearm with some difficulty in the pinch. This patient was referred for CTS decompression to the hand surgeon. Now these are the clinical photographs. So as you can see, there is a lot of wasting of the thenar muscles in the pictures we are seeing. And this is the electrophysiology. Now on the left side, median, 3.8 milliseconds, reasonably okay. The amplitudes, 12.3, well preserved. Latency, 52 normal. So this is the left side. Now we go on to the symptomatic side. So on the symptomatic side, the distal latency is 5.8, definitely prolonged. But look at the amplitudes. the amplitude is barely 300 microvolt. Compare this to 12.3 millivolt, which is correlating with the wasting we are clinically observing. There is some decrease in the conduction velocity. The ulnar, on the other hand, this is 2.7 preserved amplitude, 55 conduction velocity. Now here, carefully, if you see, there's a little bit increase in latency compared to the other side, some decrease in amplitude here also. Now we go on to the sensory conduction studies. So on the sensory conduction studies, you see that distal latency is 3, nearly normal, and amplitudes are preserved. The conduction velocity is 49. So would anybody like to comment here? Okay. So basically, why I made this point was that if something has been labeled as CTS, and you are seeing such disproportionate motor involvement in absence of a significant sensory involvement, we should always think twice. So this patient actually fits into the electrophysiological criteria of thoracic outlet syndrome. So the patient is having significant motor derangement, ulnar snaps relatively low, and preservation of median snaps. So you can see here that there is elongated transverse process, and this patient most likely has thoracic outlet syndrome. So what are the special situations where we have to have a word of caution? So the situation which we saw here, where, so the median snaps are nearly normal, and the APB or the CMAPs are either absent or low. So here one of the differential diagnosis is neurogenic thoracic outlet syndrome, or another cause like T1 root lesion, or absent thenar muscles, or maybe the patient is having a motor neuron disease. So other things should always be in the picture. Second situation, electrophysiologically, is that both the snaps are abnormal. So there, it may not be pure and simple CTS. So you can have mononeuritis multiplex. You can have a combination lesions, CTS and ulnar neuropathy, CTS and thoracic outlet. So if you're getting both abnormal, think twice instead of just labeling it as CTS. And the other things which I think I'll not go in detail. So this was a broad point I wanted to make from the electrophysiology. So broadly, if you just go through the readings, see the graph and see if it is fitting into your diagnosis, that is what is important. I would like to close, I would like to end my talk here.
Excellent talk, madam. You beautifully elaborated what are the others differentials which we can diagnose with the electrophysiologically. Do you ever find the conditions where your clinically CTS is there, but electrophysiologically is normal?
So as per literature, I think around 15 to 20% is the figure. So if you just do the routine studies and routine median, routine ulnar, around 20% can be missed. But if you combine it with the more sensitive studies, which I haven't gone into detail because of because I didn't want to bore all the orthopedicians with the nerve studies. So, but if you do comparative studies, like the earliest to pick up an abnormality is the palm to wrist. So it also depends upon how detailed a study you're doing. That will probably reduce the number, but yes, it can happen. Even they've described pure motor CTS in 4% cases. Although how do they come at that diagnosis, I'm not sure. So literature says you can have pure motor CTS in 4%, but for me, for all practical purposes, wherever I do not find a sensory abnormality in presence of a motor abnormality, I think twice.
Excellent talk, Dr. Neetu. If I could ask you one question. when there is a generalized involvement like neuropathy, say diabetic or otherwise, alcoholic, we know that the symptoms may not be exactly presenting the typical manner of median nerve distribution. It may be a glove type of distribution of the symptoms. But is there, I mean, can you actually differentiate the percentage of compressive versus non-compressive neuropathy to predict an outcome in case we want to offer a surgical treatment in such patients? Electrophysiologically, I know.
So there are certain things here. The relative studies come into picture, like I said, difference between ulnar and median. So you can make a diagnosis of CTS superimposed on a peripheral neuropathy. Peripheral neuropathy, since it's a metabolic syndrome, we would expect it to involve all nerves more or less equally, depending upon the length of the nerve. So it's a length-dependent phenomenon.
Yeah, okay. So you're talking the differential between two nerves to determine
whether the patient has a superimposed CTS or not. So then again, if there is a significant say wasting also, then sometimes EMG helps you. So if you if your Fs are absolutely normal, if you find denervation in a nerve distribution but not in a radical distribution, that might help. And this combination is actually quite common, but it is the severity and the disproportionate nature of involvement which would help us.
Thank you.
How do you come to know, ma'am, that the demyelination is taking place in these patients, and what will be the prognosis when the demyelination has started in the median nerve injuries?
See, there are electrophysiological criteria to say that this is a demyelinating neuropathy and this is the axonal neuropathy. So in demyelination, there has to be reduction by more than 70% in the conduction velocity. So broadly, in the upper limb, if it is less than 35, that is the cutoff for demyelination. The second criteria we use for demyelination is something we call as a conduction block. For example, if you're between your proximal and distal stimulation, if the proximal amplitude is 6, if your distal amplitude is 6 and second is 2, that means there is a drop of more than 60%. So that tells you that this is where the lesion is. So so demyelination for, I'm basically a neurologist, so for me, demyelination is two different things. One is focal demyelination, which happens in these entrapment neuropathies. And the ones which we deal with more commonly as neurologists is diseases like CIDP and AIDP and Guillain-Barré syndrome. So there are electrophysiological. So broadly, I can tell you, if the speed of conduction is slower, it is more towards demyelination. If the total amplitude of the CMAP or the CMAP is reduced, that means we have less axons. That is axonal. So that is a broad differential between the two of them.
So when examining this NCV studies of CTS, if there is a demyelinating disease, then what would be the prognosis after that if you are operating? Or if there is no demyelination disease, then?
For me, demyelination is conduction block. So the conduction block is happening in that particular segment where this tunnel is located. Whether you go surgically or medically depends upon the severity of the lesion. So we showed you one severity grading. It says mild, moderate, and severe. So if it is severe, then you have to operate. Otherwise, the thumb will become weak. I hope I've answered your question.
Okay, thank you.
So basically, electrodiagnosis is just extension of clinical examination, as Madam usually says. First, she examines the patient and then do electrophysiologically. So at least in our practice, we should know what are the meaning of terms given in the report. So we can also extend our clinical examination. So thank you, ma'am, for wonderful talk. And I would call Dr. Anil Bhat, sir, to continue with his talk.
So thank you, madam, for that wonderful talk. Coming to the differential diagnosis, Amit was very particular that we talk about this. So broadly, you can classify them into neurological. Most of the differential, obviously, because we're dealing with the nerve. It could be musculoskeletal or it could be vascular also. And if you just look at the list of the differentials, we might actually get scared. So this is the exhaustive list of what you can see, especially the neurological ones, right from something intracranial to outside to all the possible nerve combinations you have. But you can also have vascular or traumatic, which is musculoskeletal, degenerative, infectious, and other inflammatory kind of disorders. So this is a broad thing, but I'll just touch upon something very common ones. The most common ones is, of course, the cervical radiculopathy, especially involving C6-7. As madam has shown in beautifully in one of the cases where C8P1 can be involved as a motor component, but generally the sensory part, especially pain and other things, is more of C6-7 cervical radiculopathy with probably a compression of those nerve roots because of this prolapse and so many things. And the neck pain, which is radiating towards shoulder and then arm, and exacerbates with the neck movement. Reflexes needs to be checked, especially the proximal biceps, brachioradialis and triceps, and also the weakness of the proximal arm muscles involving elbow flexion, extension, and pronation. So these are the components which will actually differentiate it. And sensory loss is there in the forearm or in the medial palm. But what is important is the sensory nerve action potentials remain unaffected in root lesions because you have the location of the sensory nerve cell body more distally. So SNAP is usually unaffected. And it's a very important distinguishing feature from peripheral nerve lesions. So it's very important to see this component when you have cervical radiculopathy. The next one is median neuropathy in the forearm. It's the proximal compression, which is basically called as pronated syndrome. So their patients do come with forearm pain and sensory loss involving the entire lateral part. Features that favor a forearm localization include the findings of sensory loss over the thenar eminence. Typically, it's paired in CTS. And weakness of more proximally median innervated muscles, thumb flexion from FPL, wrist flexion, pronation, all these proximally innervated muscles are usually weak. But electrodiagnosis are often required to localize the site of compression. So these are the times when NCB becomes so very important for us to know whether it's CTS or something else. Myelopathy, we just spoke about. Cervical spondylotic myelopathy and polyradiculopathy usually involves bilateral sensory and motor dysfunction. So that is one important feature. Most of the time it's bilateral and may also include dysfunction in non-median nerve territories. So it need not be confined only to the median nerve component in this. The other one is brachial plexopathy, where here symptoms are suggestive of dysfunction to an individual nerve. It could be axillary, long thoracic, anterosseous, radial, median, any of these things. And examination findings more commonly reveal weakness, sensory loss, or diminished reflexes outside the distribution of the median nerve, and usually involves more than one spinal segment. So brachial plexopathy has these features. Classically might not involve just a single nerve, but can have multiple involvement. Some rare things like motor neuron disease. We usually have a asymmetric hand involvement, predominantly thenar intrinsic muscles. And most of the time, pain is not absent. So absence of pain argues against CTS, and essentially never presents with the weakness of a single muscle. That is what is important here in a classic motor neuron disease. Fibromyalgia is probably one diagnosis we all if we don't understand anything, we just put it in fibromyalgia. But of course, there are very specific criteria now. And numbness and tingling radiating down the arm. Sensory symptoms may not be restricted to the median nerve. Again, it could be very generalized or diffuse. And chronic widespread musculoskeletal pain, fatigue, that's typical of fibromyalgia is not seen commonly in carpal tunnel syndrome. Carpal tunnel syndrome patients very classically come with very specific kind of symptoms and pain. So the next component we all of us get confused is the double crush syndrome. Okay, and even though it was described in 1973, Osterman gave this very classic combinations. So you have commonest of median nerve. If you take carpal tunnel syndrome, it's cervical radiculopathy with carpal tunnel, or thoracic outlet with carpal tunnel, or pronator with carpal tunnel. That's what first three I showed. These are the classical ones which we need to remember for a double crush syndrome. So where you have a crush here at one point, but another one there, and that becomes a double crush. But this concept is being challenged nowadays. For an ulnar nerve, it could be cervical radiculopathy with cubital, or thoracic with cubital, or cubital and Guyon's canal syndrome, right? And radial nerve is cervical and radial tunnel syndrome. So what is happening with the double crush syndrome? The mechanisms which I told you earlier, this group had a major panel to study these double crush syndromes. They came out with almost 18 mechanisms, but out of these were the 4 chosen finally. One is the impaired axonal transport from proximal to distal, and they said the ion channel upregulation or a downregulation could be one of the things. Inflammation in the dorsal root ganglions, that is one thing which they found could be a cause for this double crush, or a neuromyine continuity could be there. And these are the ones which actually cause majority of the double crush syndromes. And this was a panel which studied all these common mechanisms. And prevalence of cervical radiculopathy, if you look at many of these authors, ranges from 5% to almost 94%. So this is a wide variety of, or wide range of percentage of cervical radiculopathy with carpal tunnel syndrome. Upton and McComas were the ones, 1973, as I said, were the ones who developed this first or described this first. And they talk, basically now it's spoken, as I said earlier, is multifocal neuropathy. Is a more appropriate term describing the multiple etiologies. And again, which I told earlier, it could be more of metabolic or autoimmune, diabetes, drug-induced neuropathies, vascular diseases, autoimmune neuronal damage, and compressive lesions. Of course, they all can synergistically contribute to this kind of, so it need not be just a single component of compression at proximal and distal. It could be so many things. So it's more of a multifocal neuropathy. That's what nowadays it's being told as. And treatment is primarily non-operative and relies on accurate diagnosis, very, very important. And when submitted to surgical treatment in only one of the median nerve compression points, patient evolve with worse functional outcomes. So when we have double crush, make sure that you diagnose the proximal ones properly and then only operate on this. Otherwise, if you just operate carpal tunnel, they become worse actually. That is what most of the clinical studies have proven. One of the things which we can do is to respond to local injection to carpal tunnel and see how they respond. And then take a decision whether you want to operate on that. That is one way of dealing with this double crush when you have carpal tunnel with the proximal kind of lesions in these things. Amit, should I stop here?
Yes, no, sir, you continue.
Continue with the treatment.
Are you going to elaborate?
Yeah.
Yes.
Treatment primarily is conservative. All of us know that's the first line always. We use splints, something like this. Need to be very specific, these kind of splints. So I see very bad splints a lot of times covering all the way till here. So they need to make sure that only the carpal tunnel area is well supported. Make sure it is in neutral position, not too much of dorsiflexion. Sometimes that's what patients are put. So just a neutral position so that it doesn't go for any kind of compression, especially night is where we ask the patients to wear this so that in the night when they're sleeping, they don't put their hands in different abnormal positions and cause compression there because activity is also less. So this is one of the ways to put the splint. If there's an inflammatory component or pain is a major component, we put them on NSAIDs, vitamin B12. Steroids, well, we don't use regularly, but of course, a lot of people use it regularly. And also some people also use diuretics, but I've never used that. So steroids are used for a local injection also, or ultrasound guided steroids are used. Nerve gliding exercises came in a big way, but evidence show that there is not much of improvement. So limited evidence for nerve gliding exercises. And finally, to the surgical part, when the conservative management fails, a minimum of at least 4 weeks of conservative management is what is recommended, and can wait if patient is improving. But otherwise, you offer surgical management in these patients if their activities of daily living is affected. 3 to 4 weeks, as I said, open or mini open or endoscopic. These are the options we have for surgical release. The gold standard is, of course, open carpal tunnel release. As early as 1924, it was described. Either you can do it in a local brachial general anesthesia, or nowadays even Valant. So any of these options can be used. Mini open is a 1 centimeter incision. I don't recommend it for the beginners. It's only for people who know how to do a proper open release. Mini open would be worthwhile. Less post-op pain is what people claim, and studies have shown equal efficacy, but of course it has its own learning curve. So definitely should not be tried where you can't see the structures properly. You need to make sure that you can go for a formal open release. A formal open release is where you have to visualize all the structures. So this is basically the landmark. You have the thenar crease here, the palmar crease coming in. Just about 6 millimeters ulnar to that is where your incision should be, in line with the ring finger here, because we don't want to damage the recurrent branch, the motor nerve here. So always keep ulnar always in line with the ring finger here. Okay, so this is the incision basically, right? And this is your Kaplan's lines coming. So that is the distal edge of the carpal tunnel. And you can make out that your ring finger generally touches to that somewhere near the distal end here. And just a rough estimate, but otherwise you basically draw the classic Kaplan's lines here. And you stop at the wrist crease. You don't cross the wrist crease unless you're required to, right? And if you want to cross the wrist crease, again, you have to go ulnar, curve it towards the ulnar side and not towards the radial side, if you have to not damage any of these nerves here. So this is your classical open incision. Don't be shy on the length of the incision, because even if you do 1 centimeter or you do 2 centimeter, it just takes 10 days to heal. But if you're starting off, or if you're doing it not very occasionally, make sure that you visualize all the structures nicely. Okay, go in the subcutaneous tissue all the way, right? And spread out all the tissues there. You'll see the aponeurosis coming in, the white tissue coming in there. And once you see that, you just have to make a nick for you to see the nerve. So just one part of the nerve in the proximal aspect is where you have to start your incision of the aponeurosis. Then below, a lot of times you see a muscle fiber, that is a palmaris brevis actually. So some of the palmaris brevis is quite thick. So you just have to scrape through that. And below that, you will see the transverse carpal ligament. So take off the muscle fibers. Once you take off that, you start seeing this whitish structure, which is the transverse carpal ligament. And you just have to make a small nick there, very carefully, very superficially, just to see the nerve. And the nerve is seen. So now I see the nerve there, that yellowish kind of structure. The moment you see the nerve, start protecting it throughout your dissection further. So that is all the entry you need to make. And use a McDonald's or a Freer kind of elevator here. And throughout your release of carpal tunnel, maintain this. Protect the nerve underneath this so that you don't have any chance to injure this. So cut it slowly from proximal to distal. Reposition your elevator repeatedly, because sometimes you might have entered the nerve sheath. So you just have to remove it, because as you go distally, the transverse carpal ligaments become thinner and thinner. Okay, so you need to be careful with that. They're not of similar thickness. It's a lamellar pattern, so the thickness might vary there, especially distally. So keep repositioning it and make sure you will not enter the nerve sheath itself with your elevator here. And distally, as I said, just you have to make very superficial dissections, and you start seeing the fat. And that is where your palmar arch would be coming in. So you have to be careful there. Just stop here. It will be very thin actually, the transverse carpal ligament. And that's your complete release. So that is the end of the distal edge here at that point. So that is the entire thickness of the transverse carpal ligament with its buried palmaris brevis fibers, right? And palmar flex it slightly, and under vision, you can see the deep fascia here towards the forearm, and you have to cut that. It might cause a small constriction there. So make sure you release it all the way possible till here, right? And then if you want to visualize the tunnel, you can see for any kind of tenosynovitis or any abnormal swellings or anything. So you need to go all the way till the floor of the tunnel. So this patient actually was a rheumatoid patient, and you see a lot of synovitis. There's a FPL there, and this is all the FDS covered with the synovium. Okay, so if you want to do a synovectomy at this stage, you take a decision whether you want to extend the incision. You can do synovectomy with this incision itself, but proximally, if there's a lot of synovitis, you might have to go all the way till the tunnel, the floor, and make sure you check there and see if there's any abnormal swelling, ganglions, or any of those things. And then if you want to extend, as I said, extend it ulnarly towards this, right? The palmar-cutaneous branch coming in, so you need to be careful with all these things. And then once you extend, then you can do a proper tenosynovectomy. Okay, you can send it for biopsy if you want. And these are all the nerve is firmly under the retractor here. And so these are the synovium. So sometimes there'll be a lot of synovium, especially in some patients like with tuberculosis, rheumatoid, and you can send it for biopsy for these things. Coming to endoscopic release, it could be single or double portal technique, has a steep learning curve, and surgeon should have very low threshold to abort and convert to open procedure whenever there's a problem with the endoscopic. That's very, very important. So keep not trying and doing the endoscopic just because you want to do it, whether there is a lot of difficulties through that. And this is the basic instrumentation of endoscopic carpal tunnel release. You have the regular camera, you have the light source, which is used for any arthroscopic procedures. This is the basic endoscopic. This is the blade, and this is the handle, and this is a scope. Okay, and the scope goes inside, and it is attached to the blade here. These are all the different dilators for the tunnel. This first one is called a synovial dissector, and these two are the dilators, and this is what's called the hamate finder. So you have these three things just to dilate the tunnel, and this is how the assembly is done. The scope goes to the handle here, and then the blade comes to it here. These are supposed to be disposable blades, but we use it a couple of times after gas autoclaving and sterilization rather. And if you press the handle there, the trigger there, the blade comes up like this. So this is how the mechanism works here. I use a single portal technique, and that's the camera attached to the scope here. And then you have the light source coming in, right? And you can turn this both sides. You can use both sides, right side or left side, just by turning the handle. I'll just show you that. So this is how the light is seen once. So if you just want to change the handle, you just have to turn it here and then pull this knob out and change the direction of the blade. Okay, so you can use the right side or left side both ways by just doing this particular maneuver. So this is the basic assembly of the endoscope itself. Okay. Now for a beginner, again, the incision needs to be a little wide compared to what we routinely use, right? You have the FCR there and you have the FCU there. So that is the interval we go here. We know that the nerve lies between the palmaris longus and the FCR, but here we take a slightly wider approach here, especially in the beginning. But nowadays I don't do this. I just take a small incision here. So that is a wrist crease here, and that's your pisiform, and that is your hamate. So these are all the landmarks you need to mark, especially when you're starting off. Okay, and you draw your Kaplan's interval there. Okay, in line with the ring finger. That is the first line which goes there. And then along the thenar crease, you draw the other line. So you don't have to draw the entire line. So that is a junction where, and these are all the wrist creases. So some people have 2 wrist creases, some people have 3. And normally I put the incision between the wrist creases because the wound heals better actually. Otherwise, patient keeps moving the wrist at the wrist crease. So that is one tip personally I use, even though the manual says that your incision should be on the wrist crease. So once you go in there, you have the deep fascia here, and you need to mark that if you want to, but basically what I'm trying to show is that you need to create a flap of the deep fascia, a distally based flap here. And once you release that, you'll see the nerve directly underneath. Okay, so that is the flap, and sometimes you can just snip off that the deep forearm fascia and cut it out, but otherwise you can just retain it as a small flap there for your scope to get in. Okay, so this is the kind of inverted U kind of a flap I'm raising from the deep fascia there, and just below will be the nerve. The yellowish structure will be the nerve, and once you get in there, you have to start dilating the tunnel. So you can keep that flap there, or you can take it off, doesn't matter, right? So just showing that flap again, and then you start dilating the tunnel itself. So this is the first one, which goes as a synovial dissector. So if there any kind of fibrous tissue here or synovial tissue here, you just have to free that area, but it should not pass beyond your distal edge here. So you keep one finger throughout. This is the first dilator which comes in. It goes from the ulnar side like this. Okay, so you can feel the hamate coming in here at this point. So this is the second one, and if you want, you can use a third one, which is a much bigger one. Some tunnels are quite tight, so you might have to use the third one. Otherwise, 2 dilators enough, and you should never push it very hard. It needs to go smoothly. Okay, otherwise you'll stretch the nerve, and then the light will tell you where exactly your scope is. Okay, that's very important. So again, not to go beyond that edge of the tunnel. So as you go in, you will start seeing these transverse fibers here. Okay, and that is a very classical transverse fibers you have to see. If you don't see that, maybe you're in a wrong path. So make sure that you see that. And the distal edge, you'll see that fat there. Okay, so sometimes the distal edge is not very clear. And if it's not very clear, you should not be trying and cutting it there. You might have to abort. But otherwise, from the top also, you can push your thumb and then check where your distal edge is also. That's what I'm doing there. And once you get that, you push the blade up, hook it up, and then cut the ligament. So this is how you do the endoscopic release. So all the way you come till the disc, and then you can go back there, and if some fibers are left behind, you need to start cutting them. So sometimes there could be some synovial tissue getting caught in your blade, so your cut might not be very clear. So you just have to go and see this. This is the cutted node. There are some fibers still left. Okay, so the distal 2/3 is cut. So that is what you see, the palmaris brevis from inside now. This is the cut edge now you're seeing very clear. There's few fibers of the distal part left behind. And once that is done, if you go proximally and cut this, what happens is the fat will prolapse, especially from the proximal part. Okay. So I'm coming more towards the proximal aspect, and this fat prolapse means your complete ligament is cut. So that's what it tells. And you can go in. So this scope is basically not to explore the tunnel. It is only for you to cut the ligament and come out. That's all. You're not supposed to explore the tunnel and see what's happening inside, because the nerve can prolapse inside, escape from under the blade and prolapse inside, and you might injure the nerve. So you just have to inspect it and then come out. There's the cut edge of the ligament on this side, and you just have to come out after that. So that is a basic procedure to be done. And sometimes you, as I said, you might not be able to see the distal edge very clearly. These are the times when you have to abort the procedure. Proximally release the fascia to a certain extent, as much as possible under vision. Okay, so that the tightness goes, and then you close this. So this incision can be very small as you go and learn these. So sometimes you see a lot of synovitis like this. You might not see the distal edge properly. These are the times you should not be trying to do this endoscopy. You should abort and come out. And so always take a consent for both open and endoscopic release. That is very, very important. So you see it becomes blur here. There's a lot of fluid inside. So if you're not very clear of these things, you should come out and not try to do these things. Post-op mobilization with splint for 1 week. light work by 3 weeks with a night splint, scar massage, hand therapy. For me, endoscopic release, the only reason I do is because there is no scar in the palm. That is my major reason. So the patients are quite happy. Otherwise, most studies show that there is no difference between endoscopic release and open release. Open release, there could be scar hypertrophy, tenderness, or pillar pain. Sometimes injury to the nerve, tendon, or CRPS type 2, or persistent pain and recurrence. Now, if you have a lot of weakness, motor weakness, we do what's called as the Kametz procedure, where we take the aponeurosis of the palmar aponeurosis, and then what we do is we do it and transfer primarily for patients with very bad thenar atrophy. You see this patient with a lot of wasting here and motor weakness. These are the times when you might decide that they can start their work. There are two schools of thought where the nerve, see the nerve, how much it's bulged and how much it's narrowing. It's classic hourglass contraction here, and the thenar muscle is completely atrophied in this patient. So we have harvested the palmaris, aponeurosis, palmar aponeurosis here, and there's one transfer which actually doesn't follow the rule that it doesn't go an opponent's doesn't go to the thumb with a pulley. It just goes straight, which means the lever arm is not very good for this, but it is good enough to do most of the activities for the patient. And it gives immediate relief in terms of motor weakness for the patient. So that is why we do. Otherwise, there are schools of thoughts where they say you release the carpal tunnel and slowly this comes, the power can come back. But with a gross atrophy like this and a pre-op motor weakness documented, it's worthwhile to do these kind of procedures for the patients, where you stitch it to the abductor pollicis brevis and also to the capsule here, and make sure it's in a good position. Otherwise, most opponents will go through a pulley system here on the ulnar side. Okay, so suture it both to the APB insertion and also to the dorsal capsule here, and snugly fit it nicely so that patient can start actually moving it quite early. Okay, and at the end of your surgery, the thumb should stand in a good position. That's very, very important. So the tension needs to be adjusted in a very nice manner. So this is Kametz procedure, where the palmar aponeurosis from the palmaris longus is being transferred to the abductor pollicis brevis, primarily after carpal tunnel release. So the thumb needs to have a good tension and it needs to stand in the position like this. Okay. So in summary, diagnosis predominantly clinical for carpal tunnel syndrome. There is no gold standard investigation. NCB and EMG or nerve conduction or electrodiagnostic studies are reference standards actually. Investigations to know the differentials, altered anatomy and physiology is very, very important. That is when the NCB becomes very important. Treatment is based on patient symptom severity, and complications are uncommon, but if it happens, it can be very devastating at times. Thank you so much.
Wonderful talk, sir. Do you release anti-brachial fascia?
Proximally, you're asking. Yeah, that's what I showed. That is the anti-brachial fascia. That's the forearm fascia which we release.
So, to which extent you release?
Just about a centimeter or an inch. It all, again, you can feel it how tight it is. Some patients you feel it's quite tight. So that is the time you release a little more. Otherwise, generally, some patients it's quite thin. Each patient is different. As we do every time, we know when you hold it and you hold it with a scissor, you feel the tension a lot of times. And if it's very tight there, I would release a little more. Otherwise, if it's very thin and flimsy, I would just give it a centimeter release.
So, any other point to be discussed? If not, because we are getting late, so I will invite Dr. Parag Lad to.
Can I share my screen?
Yeah, please. Yeah. Then we'll discuss also.
Is my screen visible?
Yes, sir.
Yeah. So I would like to present a case in a 55-year-old female whose left side carpal tunnel release was done and she was symptomatically better. And then right side carpal tunnel release was performed, but up to 5 months, there was no improvement in terms of symptom. So this is the pre-op function that she was, the opposition was not happening at CMC joint level. She was just doing a adduction and abduction and this kind of movement, and there was no opposition possible, and there was significant Tinel sign at the operative scar mark, and there was, absent or significant, the 2-point discrimination sensations were more than 10 millimeter for index and middle finger. So this was at 5 months post surgery. I would like to request opinion from Dr. Anil Bhat, whether at 5 months would you like to repeat EMG or would you like to consider sonography, or you would straight away offer an option of exploration and consideration of resurgery.
I would like to know what happened to the patient in terms of the surgery on that side. So if you see the scar, it's quite ulnar, one thing.
Yes. Yeah.
And so I would like to know what's happening there. So my primary investigation would be an ultrasound to see what's happened to the tunnel and what's happened to the nerve itself. Okay. And of course, I would then add up definitely a nerve conduction with EMG, but my primary investigation would be an ultrasound in this patient.
Okay. So we did ultrasound and the ultrasound just showed significant fibrosis around the median nerve, and there was even there was some flexor tenosynovial tissue hypertrophy also was noted. And she was, my ultrasound guide, the sonologist was not making an absolute diagnosis, but then she said that either the ulnar nerve is too close to the median nerve or there are two possibility of two neural structures in this hand. Then I thought it could be, the scar, as Dr. Bhat rightly pointed out, the scar is definitely more ulnar as compared to what we take it for routine carpal tunnel release. So with that keeping in mind, probably they have opened the Guyans canal and carpal tunnel together, and at 5 months, because of the fibrosis, both the nerve structures are looking together. So we decided to explore, and to our surprise, we found there was a bifid median nerve. The median nerve was, there were two median nerve in that patient, and this is the proximally, one arrow is showing a main trunk, and then there were two nerves that were present in her case. That was the palmaris longus that we harvested for gametes transfer. So as you see, the nerve also there, that is looking quite edematous, contused, and apart from that, there was a significant flexor tenosynovial hypertrophic tissue, which was probably missed in the initial phase, and which we learned in today's session with Dr. Bhat, that if there is a significant pain in terms of apart from numbness and tingling, so please keep one doubt in mind that apart from carpal tunnel syndrome, there could be a hypertrophic synovial tissue. So this was our the finding intra, and previous surgeon, probably because he did by mini open surgery, mini open technique, he decompressed only one median nerve, and the symptom did not persist, did not relieve after the surgery. And this was on exploration a thinner motor branch from one of the median nerve. So she had only one thinner motor branch of the median nerve. So apart from proper decompression, to complete tenosynovectomy, we did a gametes transfer also by transferring palmaris longus to abductor pollicis brevis. And at around 4.5 or 5 months post-op, the numbness was significantly improved, though she was complaining of some paresthesia. Tinel sign was definitely much improved, and opponentsplasty also worked very well. So the message here that I would like to give to all the viewers, that in recurrence carpal tunnel, we must consider ultrasonography as a main important investigation to look for anatomy of the nerve, to look for flexor tenosynovial tissue and to plan our next subsequent surgical intervention. This was my case. Thank you, Dr. Amit. I would like to present another case as per Dr. Amit's opinion, and or Dr. Amit Varade let him present. And I am happy to answer if there are any discussions about this case.
Sir, when you consider that your previous surgery is failed.
Okay, so the previous surgery is considered failed in my opinion, after the carpal tunnel decompression, usually at 4 to 6 weeks, patient start telling us in the OPD that at least their nocturnal symptom, their night cries has significantly improved. So in the first improvement is in they sleep better at night. That is number one. Number two is paresthesia, hypoesthesia, or sensory improvement. They start feeling it at 2 months. And motor improvement is little delayed, but honestly, 3 months later, either the patient comes for opposite hand surgery, or if there is any problem, then only they turn up in OPD to show up for no improvement in symptom. Otherwise, a pillar pain or a scar pain remains for 3 to 4 weeks maximum. But after 3 months, if the patient is coming to us regularly with complaining of pain and complaining of positive tinel sign and decreased grip strength and no improvement in symptoms, so at 3 months it will give me a warning signal that we should consider investigating that case.
Can I ask you one thing, Dr. Parag?
Yes, please, sir.
Did you have a original pre-op nerve conduction study on this patient?
Yes, sir. We had original study, and as usual, the report was moderate to severe bilateral sensory neuropathy with chronic degeneration. So, but that previous report did not mention, but I did not do sonography in the previous report, sir.
Okay. And the other thing is because if you had previous sonography, because it's very interesting to see a bifid median nerve and the way you showed the pre-op video.
Yes,
I think it would be worthwhile demonstrating the post-op video as well, because that will probably give you a very good comparison to what you have achieved, and definitely a very interesting case.
Yes, sir. Yes, sir. Dr. Amit, should I present or Dr. Varade is presenting?
Yes, you carry on, sir.
Okay. So another case that I would like to show another case of interesting case. Again, this patient was operated for right side carpal tunnel release. Okay, as we see a scar there, she recovered from probably opposition was much better, but she had significant positive tinel sign at the scar site, and her main concern was no improvement in sensory symptoms at 5 months post surgery in index and middle finger. Otherwise, she was, motor deficit, she was much recovered. But she was absolutely not happy with the numbness in the index and middle finger. Being a housewife, 48-year-old female with thyroid and early diabetic history, she was worried whether this numbness, if that is not getting better, then holding a sharp object or a hot object will that cause burns or something. So there were two causes of concern. One was no improvement in sensation, and second was significant tinel sign at the operative site. So may I ask Dr. Amit Varade or other senior faculty from our group that how do we proceed? Will you again consider a sonography or a nerve conduction study at 4 months or 4.5 months post surgery in this patient?
Yeah, I would definitely go for ultrasonography.
Okay. So because of paucity of the time, I will show what was the. She did not have CRPS or a reflex sympathetic dystrophy. As you can see, the thenar muscle gain was very good, but the concern was only index finger and middle finger numbness. See how nicely the sonologist has reported. They have reported with the diagram that there is a iatrogenic injury while decompressing the median nerve by mini open technique, and anterior 1/3 fascicles of the median nerve in the carpal tunnel were injured, and that was the probably that was the reason of positive Tinel sign. I do not know with this much involvement of trunk of median nerve can give no improvement in significant sensation. But at this, with this sonography report, I would request all the faculty member whether will you give option of exploration at 4 months, or you would consider treating it non-operatively. And even if you consider exploration, what would you, I mean, what will you counsel the patient, whether sural nerve grafting or something like that? How will you proceed now? Yeah. So what? Yes, sir. Yes, sir.
So it's finally that it's the disability of the patient. And if she's coming back to you repeatedly with this, and you know there's a neuroma continuity which can form because of this partial damage to the nerve.
Yes, sir.
Right? It's always worthwhile to go in and go and repair it back with whatever ways you want. You want to put a graft there, or you want to, how do you want it is all, I mean, they talk about some glue material and everything there.
Yeah. Yes.
So was that used for skin closure? What was it?
Yes, sir. So correct. So that was used for skin closure. And I discussed with the previous the surgeon who operated this case, and he said he had not put any glue, and there was only a scar tissue around the median nerve. So as per, I mean, even I consider exploration of the nerve, and then I converted that mini open carpal tunnel to complete open carpal tunnel surgery. And then, so this was the main trunk of median nerve. For the viewers, you should never use skin hook to feel the median nerve. This is, I am very gentle. My skin hooks are away from the nerve. Please do not take this message. And what I am seeing is a fibrotic or injured nerve after the main trunk into the carpal tunnel. So, and I was actually, because the patient had good opposition, I was not courageous enough to, cut at this level and do a sural nerve grafting. So I thought I would rather treat the significant tinel, which is causing more disturbance to the patient. I covered this scar tissue by applying a proper glue around the scar tissue. And I had warned the patient that I don't know whether my surgery is going to give you sensations back, but time will tell us. But definitely it will improve the. So this was on exploration, the injured or exposed damaged nerve fascicles with fibrosis, and this was like on the picture on the right side, a properly formed, well glued nerve. So with this surgery, after the scar healing, in 4 to 6 weeks time, Tinel significantly improved, but she was not happy from the sensation point of view. I was concerned whether now should I offer her, index finger and middle finger digital nerve, sural nerve grafting or not. But right now she is happy from the no pain, and Tinel recovered. Now I would like to ask the faculty whether her 2PD from 2 millimeter has improved to 8 or 10, and now we are at 4.5 months post surgery. But that is very subjective feeling, in my opinion. She is not, from her face, her sensations have not improved to that maximum mark. So Dr. Bhat or Dr. Varade and Dr. Vyas and Purnima madam, may I know whether your surgical plan would have changed after looking at this picture on the left side? How you would have done the surgery in your experience? Dr. Purnima madam, any valuable inputs from your side? Dr. Amit Vyas, how you would have tackled this situation? You would have considered.
In my view, because for the median nerve, sensory component is quite important. So I would have dissected the motor part, as you told that it was intact.
Yeah.
Then I would have grafted on the first go.
Oh, okay. To the digital nerve of the index and middle finger. Common.
I thought what I find that you found the scarred nerve.
Yeah. But beyond this point up to mid palm, practically, I definitely would have, I would have had to go up to the distal palmar crease to identify a intact, a good digital nerves, to grab this area. But my only concern was while doing that, if I would have damaged recurrent motor branch, that would have caused more disability, in my opinion. So that's why. And then it was we were dealing with 4.5 months from post previous surgery, plus she was symptomatic for carpal tunnel for almost 6 months from the first surgery, and early diabetic with thyroid. So I don't know whether the intrinsic damage to the nerve is how much, if so that's why the dilemma, I thought this would be the best in terms of the benefit of the patient.
Can I ask you one thing?
Yes, please, sir.
Would you consider something like a bioconduit in such cases? Because I think this is perhaps the right case to consider a bioconduit to see whether there is axonal recovery and do selective fascicular resection, maybe under magnification.
Yes, sir.
Do you routinely use loops or any other magnification for such kind of case?
Sir, this case I had dissected under microscope. I had explored the carpal tunnel under loop magnification, but then the internal neurolysis was performed, or a microneurolysis or epineurolysis was performed under a microscope. And I have personally no experience about using a bioconduit. And in this case, for a bioconduit, both the sides of the nerve ending should be of similar diameter, probably. Here, the proximal diameter is really very large, and the distal diameters of the nerves, digital nerves, are 2 or 2.5 millimeter in thickness. So I did not think about it, but it is definitely
the reason I'm saying this is that you have an excellent motor recovery, and our problem is very, very specific.
Yeah,
so,
very right, sir. Yeah.
I feel even giving a try for a bioconduit, though the distal diameter is less, is perhaps worth. This is perhaps the only case. I mean, this particular case will perhaps have more benefit of a bioconduit, if not others. Because the motor recovery is very good, and she has a very, very specific problem which needs to be addressed.
Agree, sir. Agree. Yeah, good suggestion, sir. Thank you. Should I stop sharing the screen, Dr. Vyas?
Yes. So I invite Dr. Varade, Amit Varade, to share the screen.
I'll share. Can you see my screen, Amit?
Yes, yes.
Yeah. So this is a very simple case which we routinely came across in our OPD. This 54-year gentleman presented with severe night pain, and he had tingling of left thumb, index and middle finger, and he was not able to make fist of his left hand. So from this clinical scenario, it is obvious that the patient is having carpal tunnel like symptoms, and he must be having carpal tunnel syndrome. But whenever we see these patients, we should examine him properly. So on examination, we find out that there was swelling of the distal forearm, and that swelling was moving with long flexor tendons, and there was quite significant tenderness also at the distal forearm. So when we see such patients, what should be our approach? What investigations we should advise to the patient? So, Bhat sir, what you will advise?
So when you say that patient is not able to make a fist, you know that there is a problem with the tendons itself in terms of the gliding, which means probably tenosynovitis with the classic swelling which moves on the tendon movements. So I would work up for all the inflammatory markers and also do an ultrasound to see the extent of the tenosynovitis to plan your tenosynovectomy if required. But before that, yes, if there's any role for medical management, I need to check that. Second, you need to rule out infections. So it could be your ASR CRP, which would give an indication for that. We have seen a lot of tuberculosis presenting like this. We have seen in our part, especially in the coastal regions, we have seen Mycobacterium marinum infections presenting with atypical mycobacteria presenting with infections like this. It could be a compound palmar ganglion. So any of these differentials have to be kept in mind.
Yeah, right, sir. As sir said, these are the differential diagnosis which we should consider in this patient. So according to that, we did investigations, and the inflammatory markers and all, they were negative. The test which really helped us is ultrasonography. Ultrasonography has shown that there was tenosynovitis of the long flexor tendons. So in such cases, the carpal tunnel, apart from the conventional open carpal tunnel release, we have to extend the carpal tunnel, and on exploration, extend it proximally in the forearm. And we found that there was severe flexor tenosynovitis of the long flexor tendons, and there was severe compression of the median nerve due to that. So we did flexor tenosynovectomy, extensive flexor tenosynovectomy was done. And these are the intra findings. And we can see that there was swelling of the median nerve also due to the surrounding tenosynovitis, and compression at the carpal tunnel level. The nerve literally became flat in the tunnel. So extensive tenosynovectomy was done. After that, we can nicely see long flexor tendons, and median nerve was also done. Sort of external neurolysis type was done for the median nerve. And once we did that, now we can nicely see that nerve is free from compression now. Still it is flat at the level of the carpal tunnel. So eventually this patient recovered nicely, and now he is able to make feast and do all the daily activities. So the message here I want to give is, whenever we see symptoms of carpal tunnel syndrome, we should think what is the cause. We should keep in mind differential diagnosis. There may be some sort of increased content in the carpal tunnel, and these are the differential diagnosis which we thought, such as flexor tenosynovitis, tuberculosis, some cyst or ganglion in the tunnel. And this time, in these cases, ultrasonography will help you a lot, and accordingly you plan your management rather than just going and releasing the median nerve. Thank you very much.
So, Amit, what was your diagnosis after histopathology?
It was, we sent it for histopath, and it was non-specific tenosynovitis.
So that's the usual diagnosis.
Yes.
Chronic non-specific tenosynovitis.
So my question is that, suppose pre-operatively you have ruled out all the infections, rheumatoid arthritis, and most of the time this is the diagnosis. So particularly in these type of cases, does steroid injection helps?
No, in a sense that we're talking of local steroid.
Yeah, local steroids.
Dangerous because you've done a thorough tenosynovectomy of the tendons, right? And it's such a big incision, so the steroids will definitely cause more damage. There could be a chance for tendon ruptures. The wound might not heal, and I think literature has shown that local steroid is absolutely useless for these kind of conditions. So you should not be doing that.
Not post-operative. Instead of doing tenosynovectomy.
Okay. No, even then, I think it's not worthwhile to do a local steroid injection for this, because Amit has shown that it's more of, now it's becoming more of a mechanical kind of a issue also there. It's not just inflammatory. It's causing fibrosis. It's causing reduced gliding of the tendons, and it's causing the increase in the content of the carpal tunnel itself. So it's more of a mechanical issue right now. So you have to remove it. That's very, very important. One more thing, Amit, was that routinely send all these for not just histopathology, for all the tuberculosis workup also, gene expert and culture and everything. That's very, very important. Yeah, I mean, culture sometimes gives, even gene expert will be negative, but culture might give positive after 6 weeks. We never know this.
Okay.
Yeah, so we have to wait till 6 weeks and get the report for culture, and then only take a decision for these things. We have seen a lot of patients having those positive reports later on, much later on. Yeah.
Okay, sir.
Okay. So any other questions from?
So Amit, I hope all presentations are over.
Yes, sir.
So at the end, I would like to ask all the esteemed faculty members from questions from a common orthopedic surgeons practicing in the periphery. So all the esteemed faculty members very well describe the clinical diagnosis of carpal tunnel, but most of the time in the periphery, the NCV EMG studies are not available, or even though if they are available, they are not properly conducted by the person who is doing those studies, and results are not validated. So what is your opinion, how to proceed for the treatment? What are the specific absolute indications for the surgery for such kind of patient? How long these patients can be managed conservatively? When to refer such patient to a specialized hand surgeon? These are the few specific things for the orthopedic surgeons who are practicing in the periphery.
I would like to give my contribution to this question.
Yeah.
That, number one is if signs are more than symptoms, that is first criteria. Second is history of nocturnal disturbance. And even in today's era, computer typing, mobile working, kitchen, while working in a kitchen, while talking on phone, while cutting vegetables, all these symptoms, they definitely give numbness and they shake their hand. So significant numbness in the distribution of median nerve. Third important criteria is paresthesia. All patients in early symptoms may not have anesthesia or hypoesthesia, but they have paresthesia in the thumb, index, middle, and half of the radial half of the ring finger. Fourth criteria, little delayed presentation, is abductor pollicis longus, opposition deficit. And fifth important criteria is Duncan test as well as a positive Phalanx test. And with these criteria, usually patient comes to us either referred by neurologist or a family physician with EMG report. So, but then if they come to us directly, we need to discuss with the neurologist that my finding is carpal tunnel or my observation. Always ask the patient whether they have numbness in all 5 fingers or whether they have numbness in main 3 fingers. Because otherwise you may miss Guyon's canal compression also, which is not very common, but it is not that uncommon also. So this is how I would proceed.
Most of the time, the patients are maybe 100 kilometers or 150 kilometers from district headquarters.
Yes,
what
sir.
is the specific indication to advise such patients for EMT or NCV? Otherwise, you can start the treatment directly, conservatively, or the surgery. So, what is the specific indication? Number two, my second part is, if patient is having the comorbidities which may contribute to the peripheral neuropathy, should you advise a common orthopedic surgeons to go for surgery even if the signs are more than the symptoms?
Dr. Anil, you would like to take over?
I think it's just sticking to the basics, sir, all the time. I mean, whether it's general orthopedic surgeon in a periphery or in a hand surgeon in a big city or wherever, I think all of us should just stick to the basics all the time. Repeat the tests the same way all the time. Document the same. Talk to the patient. Listen to the patient the same way all the time. Ask for the history. Find out how long they've been having it. Do the same Phalanx Test, Pinel sign. Start them on conservative management. Always wait and splint and this one. If they have diabetes, hypothyroidism, treat that. Go slow on these things. There is no hurry to do NCBs. There is no hurry to do surgeries. So it's always that we have to follow all the basic steps, which I think all of us have told in our talks. There's no, I mean, I showed endoscopic release, but that's not, that's only very few times which we would want to do. But otherwise, the basic things of each and every step, right from history to clinical tests and additional investigations when required, I think all of us will follow the same thing. And yes, if somebody has a doubt of, that they've not been able to diagnose the carpal tunnel or they suspect something more is happening, yes, further studies of NCVs and EMGs can be asked for. But otherwise, there's no harm in starting them with a splint, starting them with vitamin B12. And if there's pain is a component, give a short course of NSAIDs, ask them to come back after a month or 6 weeks, then take a decision. There's no emergency in this, absolutely. Right? Patient coming to you is not under your control. So if patient comes late when they have a classic thenar atrophy or weakness, that is the time we might have to hurry for the release. But otherwise, absolutely no hurry to do anything. Give them time in terms of conservative management. Give them time to go to the best place for them to at least get their investigations. And then once you're convinced of that and the symptoms, your conservative management is not working for the patient, and the disability is persisting for the patient. If this lady can't milk her cow, or she can't do her housework, or she can't do her typing or anything, she's a teacher, she can't do anything. Give the choice to the patient always, that let them choose when they want to get the surgery done. A lot of times I ask the patient, you want to get the surgery? They will always tell me that this is the time I want it. So they will definitely decide, or it should be a shared decision always with the patient. I think this can be done anywhere, any remote place. Absolutely doesn't change for us.
Thank you, sir. You described very well. One more last question from Neetu ma'am. What is the role of this pregabalin, gabapentin, and such kind of drugs in the treatment of carpal tunnel syndrome?
Most of us would give a combination of vitamin B12 and pregabalin for a short course of maybe 3 weeks to 4 weeks. And that is where, when the component of paresthesia and numbness are very severe, I would add a pregabalin along with vitamin B12. But a lot of times, again, I ask the patient to get back to me after a week once I start them on pregabalin to see how they respond. Each patient, I mean, some are really drowsy, they really follow up with pregabalin and gabapentin, and some tolerate it very well. So I've always asked them to give me a feedback after 1 week of starting. And if they're tolerating it, I usually start with 75 and then go to 150 and then go slightly higher if they're tolerating. So paresthesia and numbness being a major component, that is when I add that. Otherwise, I go with a combination of NSAID, short course of NSAID, and then with vitamin B12 only. That is how I take a decision.
Neetu ma'am, would you like to add something in this?
Yeah. In practice, I find pregabalin quite useful. As neurologists, we are anyway using pregabalin in a lot of neuropathic pains. Typically, what I would do is, as was stated by my earlier speaker, when the paresthesias, the tingling component is very disabling, frequently disturbing sleep, you can start with as low as 50 milligrams. Nowadays, some of the companies are even having 25 milligram. They have a scored tablet which you can use. So you can start with a very low dose in addition with a splintage. A carpal tunnel splint, it does give symptomatic relief to the patient. And you can escalate as per patient's tolerance. So in clinical practice, like my previous speaker said, patients would like to time their surgeries. Even if they are a surgical candidate, they would want, once the vacation of my kids start, or, once I'm free from XYZ urgent work. So that does give a breather. As far as drowsiness is concerned, you can start low. I routinely would not give a daytime dose with carpal tunnel. I'm very happy with my nighttime dose, and so are my patients. Only in the ones where these paresthesias are very disabling in the day would I give something in the morning. Although ideally we dose pregabalin twice a day. That's a standard dosage. But somehow in CTS, even once a day works very well.
The only
Thank
thing
you.
I would tell is not to give those combination drugs because there the vitamin B12 dose is also less, and this also. If you want to give vitamin B12 separately as 1,500 micrograms as a separate tablet, and pregab is separate. The combination of this with so many other things, with all vitamins, cysteine, that and this, that is the worst thing which patient complains with giddiness and everything. So always split them into individual drugs and then give them separate.
So thank you. Any other faculty would like to ask any questions? Otherwise, we are at the end of this webinar. Okay. So on behalf of Rajasthan Orthopaedic Surgeons Association, I'd like to thank our guest faculty, Dr. Anil Bhat, Dr. Anil Varade, Dr. Parag Lad, and Madam Neetu for excellent talks and presentations and case discussions, everything. So it was a nice webinar, everything for carpal tunnel syndrome. So thank you so much. Thank you to all other faculty members who has taken part in the active discussions. Thank you to OrthoTV for providing platform for this webinar. And thank you, Purnima Patni ma'am and Dr. Amit Vyas for moderating the webinar very well. So thank you so much.
Thank you, sir.
Stay
Thank
safe.
you. Right.
Bye.
Thank you, sir.
Thank you.
So much. Good night.
Thank you, sir.
Thank you, Amit.